patients with heart failure face an enormously complex set of challenges on a personal level. So from the patient's perspective, they have to deal with understanding their condition, which just understanding what heart failure is incredibly challenging for the layperson. So spending time understanding and getting, self-education is a component of dealing with this. Secondly, the asks of self-management are huge. So there is a complex regimen of medications that patients with heart failure often have to take. Majority of patients with heart failure are routinely on between 8 to 10 medications, some of which are specific to heart failure, and some that are related to comorbidities that many patients have. Self-management then further extends to things like measuring their own vital signs and weight and tracking that over time, and also trying to keep up with the complexities of care, going to appointments, knowing which appointments to go to, going to multiple specialists at the same time. So the complexity is clear, and in order to deal with complexity, patients need to truly have the faculties to deal with it. And as it turns out, we start off the statement by clearly describing a huge literature of many decades that describes how common cognitive impairment is in these patients who have heart failure. And, sometimes you go into the room and you see a patient who clearly, has dementia and is impaired and can't talk to you. That's not even the kind of patients that we're talking about in this document. We are talking about cognitive impairment that's invisible, cognitive impairment that's nuanced, that's not obvious just by talking to somebody. That is the challenge that we face with these patients. We go into the room, we go into the clinic space, we talk to them on the phone or by video, and it's not clear that they have impairment. The impairment is modest, but it's real. And, the areas where that impairment is most often found is, first of all, in the domain of learning and memory. And obviously, patients need self-education. So if they have problems with learning and memory, they're right off the bat, they're going to have a deficit in understanding what they're even dealing with. And the second most common cognitive impairment domain in patients with heart failure is executive function. Executive function is problem solving, complex problem solving. So in complex problem solving, the ability to do complex problem solving is inherent in heart failure self-management. So taking 8 to 10 medications per day, figuring out which bottles to open, where to put, whether a pill is taken twice a day, once a day, every other day, 3 times a day, or a diuretic needs to be taken as needed, and you need to tie that with changes in weight or edema or shortness of breath. So it's very complicated, and that depends executive function to work at the highest level, but that is very, very frequently impaired in patients with heart failure. So, the reason that the Heart Failure Society of America decided to elevate this topic to the front, to the front of the society is because cognitive impairment is very, very highly prevalent. Depending on where you read it, and which subpopulation you're interested in, it could be as common as nearly 78% of patients have some element of cognitive impairment. And therefore, we are all dealing with it. Certainly, every heart failure clinician is dealing with it, but as we started off this conversation, that this is all clinicians who take care of these patients, even if they don't view themselves as cardiologists or heart failure clinicians. If they touch these patients, they need to be aware. They need to be aware that there is a very high chance that the patient in front of you has cognitive impairment, and they need to understand how to diagnose it, and I think they need to understand how to manage it when it's present. a lot of times we approach care for heart failure patients in a very standardized way. So, for example, many hospitals will have a care transitions program where they peanut butter the same set of interventions on patients being discharged from the hospital. So every patient admitted for heart failure needs to go home with a heart failure booklet. They need to be told to weigh themselves. Everybody's going to get one telephone call. You know what I mean? There's standardized transition programs that everybody gets. So I would argue that because our resources are limited and there's not enough of us, and there's not enough resources and nurses and money to go around, understanding cognitive impairment and recognizing it is actually more critical than ever. Because if you have somebody who is not cognitively impaired, if you have somebody with heart failure whose cognition is intact, and you discharge them from the hospital, the amount of interventions you need to give to that patient is going to be completely different than the amount of interventions that you're going to need to give to a patient B who does have cognitive impairment. So instead of spending all your energy, on the people who don't really need it, figure out which patients have the highest need, which patients have cognitive impairment, especially more complex cognitive impairment, and pour all of your resources into that. That's what I would argue, and that's been my experience, and that would be just a more efficient use of resources and being able to target it where it's really needed. So maybe that's one small puzzle piece, and the big question that it's impossible for me to answer. I mean, it's a brilliant question, but I don't know. I can't invent a bigger workforce, and we're not going to get much more money into healthcare, but at least the resources that we do have should be efficiently used, and we could use cognitive impairment as one tool to focus where resources should go. Because people with cognitive impairment, this is when we talk about this in the article, accommodating cognitive impairment is important. So patients with heart failure and cognitive impairment, clinicians should activate the patient's social circle much more than, for example, somebody who does not have cognitive impairment. So if somebody has cognitive impairment, you have to tell the family member or the friend, listen, your loved one, your friend, they're not going to be able to manage the 8 medications they have to take. They can't do their pill bottles. They're not going to understand how to do flow sheets of their weight. They're not going to understand how to go to clinic and that kind of thing. Those people need the most help. So that's where you should focus your energy. And at the same time, don't focus your energy on patients who don't need it. And by the way, there's a paradox here that I've seen over the years, Patrick, which is healthcare providers, understandably, are most attractive and they really want to deal with the patients who are most interactive, who are sharpest, those are the patients who need it the least. And that's the complex reality we work in. Based on research done and our experience as clinicians, I think that for non-experts, meaning we're not neurologists, we're not geriatricians or brain specialists, we're cardiologists. And you can expand that to hospitalists and internal medicines and people who are not experts in brain sciences. I think that the tool that is most helpful is called the mini-cog. So the mini-cog is a free tool. It is extremely simple to deploy. What it involves is it involves the clinician asking the patient to memorize 3 words and then to draw a clock. And then after the patient draws the clock, the clinician asks the patient to recall the 3 words. That's it. It literally takes less than 3 minutes to deploy the test. The ramp up to learn how to use it is very, very simple. In fact, several years ago, we did a randomized clinical trial and you can find that on the senior author of that one, where we created these very simple graphical cards, like a Sunday morning cartoon that shows a clinician deploying the minicog. And then we tested the utility of that little graphical tool for nurses who have never even heard of the minicog. And those nurses who got the graphical card understood it immediately on the spot. It's that simple to understand with no extra explanation, just looking at a little cartoon. So learning how to deploy it is easy. Deploying it takes a tiny amount of time. And the results are very, very important. The results are very important. So they can identify patients with cognitive impairment. Now, unlike the MoCA and other more sophisticated tools, you're not going to get a very granular understanding of why patients have cognitive impairment, or whether the cognitive impairment is, the intensity of cognitive impairment. Those are important questions that need to be answered by experts like geriatricians and neurologists. But for us, as real world clinicians in the trenches who need to work quickly and understand what we're dealing with, a tool like the minicog, I think, is perfect. Because at the end of which, a clinician deploying it will understand if the patient in front of them has cognitive impairment or not, and then they can immediately revert one way or another. So at least for non-specialists, we recommend the minicog. I think that the most pressing research need is implementation. There's a lot of voices out there talking about aging-friendly healthcare systems. And a component of being an aging-friendly healthcare system is able to identify patients with cognitive impairment. Now, what would that look like in the real world? I think that, I have this vision for a future where healthcare systems routinely and rapidly assess cognition at really a population level in the same way that they're comfortable checking blood pressure or they're comfortable checking weight. Many of us have argued over the years that cognitive impairment is a vital sign and should be treated as a vital sign and can easily be assessed like a vital sign. And the prognostic value of cognitive impairment on an immediate basis, Patrick, is probably more important than some of the vital signs that we do measure. Because it's very actionable and it has prognostic meaning. There's data that shows that patients with heart failure who are hospitalized, who are discharged from the hospital after admission for heart failure, those patients that have cognitive impairment, as compared to those who do not have cognitive impairment, they double the risk of being readmitted. So, the real world implications are huge. And I would argue the investment in implementing it is probably not large. So really trying to expanding the research on how to implement, I think, is by far the most important immediate need. And I think it could have very, very positive impact for healthcare systems, for spend, for utilization, and for patient outcome.